incidental findings on low-dose CT scans for lung cancer screening. Screening with a low-dose CT scan has the potential of discovering other malignant or non-malignant findings that may get overlooked, thus delaying the time to identify, work up, treat, and manage. This policy allows the program's APP to take responsibility and act on these findings by initializing the workup now on behalf of the patient's primary care provider. Primary care providers are updated with appointment dates and times and are CC'd within my orders I place for continuity of care. Any need for future surveillance imaging will be deferred to the primary care provider. With this policy, this has drastically improved our workflow as well as eased the patient's and provider's burden. Coordinating the patient's care allows us to better optimize the patient's overall health and survival by facilitating an early diagnosis, improving patient outcomes, enhance patient engagement in their care, and making sure no one slips through the cracks, and ultimately giving the provider back their time and accountability as we provide high quality care for each of their patients. In the next few slides will be case studies outlining our work. So our first patient is a 62-year-old female with a history of breast cancer in 2012, had a lumpectomy, radiation, and 7 years of tamoxifen, is a former smoker with a 27-pack year history, received her care out of state, and then relocated back here in 2024, underwent routine mammograms, but had gradual nipple changes and some skin thickening and a little nodule underneath her old surgical site. Otherwise, she was asymptomatic. So from the time of referral, which was placed back in the end of October of last year, that referral is just referred to NP Lung Screening Morgantown. It gets to my nurse navigator. She receives it, contacts the patient, reviews their eligibility, and makes the appointment with me to discuss the risks and benefits and ordering of that scan. And that was completed on 10/29. And then she ended up having the normal lung res 2 lung screening November 14th. Although it was a normal scan, it did show an incidental finding in the right axilla. And given that the patient had a history of breast cancer and represented with post-surgical changes in lymphadenopathy, an underlying mass couldn't be excluded. So I entered a further workup to get that done. At time of review, I placed the orders and CC the primary care provider and nurse navigator, ordered a CT chest without, that was under ASAP order to coordinate with the already scheduled mammogram the patient had for convenience, and I placed a referral to breast surgery. On 12/09, she had her CT scan, which you can see in the top left corner, that 4-centimeter lobulated necrotic mass in the right axilla that was suspicious for nodal disease. Her mammogram bilaterally was positive. And then in January, her mammogram and ultrasound was complete and ended up having a biopsy that next week at her visit with her new provider at the breast center. The care was deferred to the breast surgery onc team after the appointment was scheduled and confirmed. However, I still wanted to follow up to make sure that she was getting the care that she needed. And she did undergo that biopsy on 1/24 that was positive for breast cancer. And then she went back to hematology for an oncology appointment. And she started chemotherapy back in February and underwent an ultrasound in April of this year that showed that suspicious axillary had decreased in size. So in the top left, you'll see the patient's PET CT scan, and you can see that reactive mass right there that's lighting up with that red arrow. And she had this PET scan just under 2 weeks after her biopsy. And in the next slide, you'll see how much smaller this node is. It's incredible. And then in May, she had a CT chest abdomen. It showed it was decreasing in size. Her mammogram was okay. It showed decreased size as well of that lymph node, and underwent a right mastectomy in July. Pathology showed no residual malignancy. She started radiation at the beginning of October. The next patient case is a 68-year-old female with a history of COPD, current smoker, 1 pack per day for about 42 years, history of a benign breast biopsy, has endometriosis, and a history of a total abdominal hysterectomy. She was referred by her primary care provider for the lung screening scan alone, and the provider completed an external ordering form. She began a low-dose CT screen back in January of 23, and it was a RADS2 with a benign ground glass opacity in the lungs. And so given that this low-dose CT scan, it came back as a 4A suspicious, so that's considered an abnormal screening, and I initiate a workup. So that on the annual, it was a 4A suspicious, showing a new nodule this time, and it was recommending a repeat low dose in 3 months. She had that done in June of 27th of 2024, and it showed that it was stable in size. The next week, I reviewed that scan and I ordered a CT chest because it was given a lung RADS3 score. So I like to have the patient follow up at least 1 full year to ensure that there's no progression or no worsening of any nodule in growth, size, or appearance. And then January 6th of this year, I had a CT chest, and it showed that that nodule that was 7 milligrams, or so I'm sorry, 7 millimeters, and that was stable. And on that 3-month CT scan, now it's 11 millimeters in size. So it grew a lot within a short amount of time. And it was recommending a PET CT scan or biopsy. And below are those images from those scans. At time of reviewing this scan, I placed those orders for a PET CT and referred to thoracic surgery. On January 31, I had a PET CT scan. As you can see, that node lighting up right there. It was 12 millimeters in size, spiculated with uneven borders in the lower left lobe. SUV is 6.7. No other mets of concern. On January 31st, the same day, right after her PET, had a new patient visit with thoracic surgery for further consult and was questioning whether to do SBRT or surgery. Ended up going with surgery in March 3rd, and it showed an early stage 1 lung cancer. She was cured, and that was the end of APP coordination. Next, patient 3 is a 57-year-old female without any significant history. Is a former smoker with a 30-pack year history who quit in 2013. Received prior low-dose CT scans. The year before that, it was in October of 23 at an outside facility, and it was given a RADS1, which was completely negative, asymptomatic as well. She was a self-referral with our website using that WUFU form that gets sent to my nurse navigator and myself. And that was in March 25th. And then next week, APP telephone visit. I ordered the low dose, did smoking counseling, and then she ended up having that low dose CT scan on May 14th, and it was normal, a lung RADS2 benign read. However, on the scan, it did show that it had an asymmetric enlargement of the left thyroid, and it was recommending an ultrasound for further evaluation. The top left picture is the nodule, is a ground glass nodule in the lung, and on the bottom picture is the asymmetric enlarged thyroid. In May, reviewed it, placed a thyroid ultrasound order. Next week, my nurse navigator wanted to make sure that the patient had everything she needed to schedule this appointment, and she followed that up again back in June, and the patient was able to be scheduled for the ultrasound today, which was that on that same day in June. Patient was unable to get a referral in time. So luckily we did follow up with her because she hadn't heard from that referral to get that scheduled. That did show a TIRADS3 left thyroid. It was recommending a biopsy. The care was deferred to the primary care provider for continued evaluation and next steps. My AP coordination was complete, but I wanted to follow up to ensure this patient was going to get that biopsy done. And so I contacted the primary care provider and patient with those results and placed a referral to, the PCP placed a referral to general surgery outside of WVU, which makes it a little harder to track, but nonetheless, wanted to make sure she had this appointment. Patient had not yet reached out to that outside provider, and I called the office and it got lost in the shuffle with other facility referrals, unfortunately. So I placed the biopsy order myself to avoid delay in diagnosis to treatment. However, the primary care canceled that biopsy order and entered a referral to the outside provider again, which is okay. And then the patient was scheduled for the new patient visit, now with hoarseness, and was ordered a thyroid ultrasound, and it showed that multinodular goiter. The FNA biopsy was completed as well back in August, and it showed a benign follicular cell pathology. So they wanted to schedule surgery in October. And the picture on the left is that thyroid enlarged, and then on the right were some other thyroid nodules. The next patient is a 53-year-old male without any significant history, 1 pack per day smoker, 33 pack years, received prior low dose on the Lucas bus in spring 2024, was a benign RADS2. Recommending a renal ultrasound, though, for a left lesion it did find on the scan. And the primary care provider followed up with a renal ultrasound that was ordered and completed back in May of 2024. And the primary care recommended a nephrology consult, but the patient was asymptomatic and canceled that new patient visit. So the patient ended up being referred for an annual low-dose CT scan come June. Renal mass. This time it was suspicious for malignancy. So at time of review, I placed that PET CT scan and I referred to urology. In July, that nodule kidney was 10 centimeters, and it was on the left side. It was cystic with multiple wall thickening and different enhancements there. And SUV was very low. It was 1.4, but it was still a concern for renal cell carcinoma. And you can see in that red circle, that was the 10 centimeter left cyst mass there. I'm having a new patient visit with urology that next month in July, and clinical stage T2 and 0, and was referred for left radical nephrectomy. Had that scheduled on October 2nd. Pathology, clear cell renal cell carcinoma. Coronary artery calcifications are also being found on screenings, which is probably the main significant finding almost on all of these scans. So after the result is received and reviewed, I notify the patient and primary care provider, including any specialist, to let them know about the findings. And if there's no cardiologist specialist already, that to be referred, or at least to discuss with a primary care provider to lower the risk of heart attack and stroke. They're scored mild, moderate, or severe. And this is a scoring criteria from a diagnostic coronary calcium CT scan versus the lung cancer screening CT scan. Sort of similar. The coronary CT obviously is going to be more detailed. However, with the low-dose CT scan, there's potential for both under overscoring, potential for false positives. So that's why we have the patient discuss with the primary care provider and their history. This is a chart of the incidental findings and the orders I have placed so far of this year. So I have placed CT chest scans, 81 of them. And last year in 2024, I placed the same amount. But last year, I was also covering 4 more additional sites. Now we have another APP covering the Wheeling Reynolds section. She's doing a great job, Sarah Harmon. And so we run each program very well. And for example, referral to pulmonary, I made 27 of those this year. Referred 50 patients to thoracic surgery, 60 orders for PET CT scans, ultrasound for kidneys. There were 30 of them. and ultrasound of the thyroid, 15 orders. This is a graph of our Morgantown low-dose CT scan sites that we get it done at Ruby, Summersville, Fairmont, or Braxton. And you can see over the years from 2020 to 2025, we did grow. And however, 2023, in 2022, actually, that was when Summersville started out. But really, 2024, we gained momentum with the other facilities to really help out and spread out the patient's location so they can get it closer to their home. So we did 1,404 scans, 2025 in for Summersville, 255, and Fairmont, 377, and Braxton, 198. And this is for the Morgantown site alone for abnormals who underwent biopsy surgeries and how many confirmed cancers. So for 2025, you can see that there have been 57 abnormal ended up going through a biopsy and surgery, and 15 patients were confirmed to have cancer. Summersville, there were 25 abnormals, 2 underwent biopsy surgery, 1 diagnosed cancer. Fairmont, 22 abnormals, 6 biopsy surgeries, 4 confirmed. In Braxton, 14 abnormals, 5 underwent biopsy surgery, and 3 were positive for cancer. In November is Lung Cancer Awareness Month. So if you have a patient that's a or smoked before and they're around the ages of 50 to 77, please send them our way. Be happy to take them. And the order below is referred to NP lung screening, and the order on the bottom right is referred to tobacco counseling. Patients can also contact 1-800-QUIT-NOW. It's a free state quit line. And Melanie and myself, we were at the Pink and Pearl and the breast cancer awareness walk, and we had our table and just wanted to show you guys that, and it was a great day. And that concludes my presentation. I'm open for questions. I appreciate your time and attention.